Good morning. It is February 24th, and this is Senate Health and Welfare Committee meeting. Today, we're looking at a couple of bills. We're looking at S-239, which we went through a bit ago with our Ledge Council. That bill relates to enrollment in Medicare supplemental insurance plans. So we'll hear about that. And the time scheduled for that is 8:30 to 10 o'clock, but I'm going to sort of ask folks going through to be as concise as possible because we have a long day in front of us once we get to S-204, the freestanding birth center bill. I don't want to give short shrift to your interest, but just so we know that we want to move right along. So thank you all for being here. Greatly appreciate it. And we will ask Ruby Baker, who is the Executive Director of COVE, to introduce herself and give your testimony for the record. So thank you all for being here.
Good morning. Thank you for having me. For the record, my name is Ruby Baker. I am the Executive Director of Community of Vermont Elders, or COVE. I will be brief, I promise, but I want to share with you the role that Community of Vermont Elders plays in the Medicare sphere here in Vermont. We are the sole administrators of the Senior Medicare Patrol for the state of Vermont, and there's one in every state. We are the one for Vermont. Senior Medicare Patrol seeks to prevent, detect, and report instances of Medicare error, fraud, and abuse. As such, we handle complex cases of older adults who have been victimized. We field calls for people who are confused, and we provide public education around consumer protections. Medicare is complicated, and I'll shocker. So I'm not going to read through these. You know that Medicare is complicated, but essentially what we're dealing with are three main parts. Part A, hospital insurance. Part B, medical insurance. And these are what we call original Medicare. Part D is prescription drug coverage, and that is run by private insurance companies that are regulated by Medicare. And then you can buy something called a Medicare Supplemental Insurance or Medigap plan. These are also private insurance products that help you pay your share of the costs in original Medicare. And they are standardized. They're the same in every state. And where things get a little tricky, COVE and others on this call receive a lot of calls from confused or frustrated clients concerning Medicare Advantage. Medicare Advantage is a private insurance product that replaces original Medicare and often Part B and Medicare supplemental insurance with a private insurance product. It should be noted that an in-depth county-by-county analysis from the Commonwealth Fund found that while Medicare Advantage plan costs per beneficiary are lower than traditional Medicare costs in urban areas, they are substantially higher in rural areas. Anecdotally, we find that most of our clients who have Medicare Advantage plans are fine with them while their healthcare needs are low. But as soon as they need more expensive care, those out-of-pocket costs skyrocket. Many people are looking for a financially secure way out of these plans. And in Vermont, there's no way out without being financially penalized every month for the rest of their lives. This bill seeks to change that. It is the opinion of COVE and our Policy Advisory Committee that S-239 would benefit older adults in two significant ways. Firstly, it offers an annual opportunity to change their minds. Every other Vermonter in a state-regulated plan has that opportunity during the open enrollment period, and older adults deserve that same opportunity. I changed insurance plans this last year because I realized that insurance that I had was resulting in higher costs. So I switched. All consumers should have that opportunity. Make a different decision if that is what is best for them and their family. They should not be bound or penalized for responding to their own changing situation. Secondly, the opportunity to opt out of Medicare Advantage and to rejoin original Medicare will exert market pressure on the providers of Medicare Advantage plans. That market pressure helps control costs, improve benefits, and protect consumers. Without financially safe alternatives, older adults are trapped in plans that are no longer serving their needs but have no other options. This can lead to delayed care, increased ED visits, and medical debt. Older adults do not deserve to bear the brunt of the risk. Our insurance product should be designed to protect older adults, provide a spectrum of options that best serve their needs, and create fluidity that can allow for changing circumstances and needs that are difficult to predict. COVE supports the passage of S239. Our only recommendation would be to expand the working group, ensuring that consumer representatives from the community and key stakeholders such as COVE and the area agencies are included. We would also suggest adjusting the language in section 2B1 to include education to the public regarding these plans. Many of the challenges we are currently experiencing are as a result of the Medicare Advantage plan marketing strategies, which drown out the limited public education that the AAAs and COVE are able to provide. With coordination and support, we could create a strong educational campaign that counters the often deceptive or misleading marketing so common with Medicare Advantage and private insurance. Thank you for your time today.
Thank you. Are your recommendations, I'm looking to see, are your recommendations in the testimony that you provided? Yeah, at the bottom.
Yes, last
Yeah.
paragraph.
Yeah, thank you. Okay. Questions, committee? Clarification? That was very clear, and thank you. That was very clear and concise, and we appreciate it.
My pleasure. I do have to step out though, so
Oh, nuts. Okay, that's good.
sorry.
We
watch
won't
it,
hold you.
well, if you have any questions, I have a few more minutes, but otherwise,
We
I'll watch
know
my
Erin
video.
has your contact information, and we do as well. So thank you very much, Ruby, for being here, and we may get back to you. So thanks a lot.
Thank you so much, Senator.
All right. So let's move on to Meg Burmeister, who is from the Northeast Kingdom Council on Aging. Meg, thank you for being here, and we look forward to your testimony.
Good morning, everyone. I'm Meg Burmeister. I'm the Executive Director of the Northeast Kingdom Council on Aging. Thank you for the opportunity to testify today on behalf of S239 related to Medicare supplemental insurance policies, open enrollment, and the Medicare Advantage plans. I'm speaking today on behalf of the 5 area agencies on aging, which are located throughout Vermont. The area agencies on aging services include the Medicare and Health Insurance Counseling and Education Program, also known as SHIP, which is a federally funded program and have done so for years. We also provide meals and community meals and Meals on Wheels programs, long-term care coordination, caregiver programs, wellness activities and programs, and information and assistance for almost anything that people call about in relation to aging in Vermont. Additionally, we provide assistance and outreach for applications for a state pharmacy program, Medicare low-income beneficiary program, housing, fuel, and 3 Squares Vermont. So as you can see, we do a lot and have been doing it for a long time. And Medicare is a key piece because anyone over 65 is enrolled in that health insurance plan. Our AAAs provide Medicare and health insurance information to empower, educate, and assist people through objective outreach, counseling, and training, including open enrollment for people who are new to Medicare. And these SHIP counselors participate in trainings throughout the Administration on Community Living and the Center for Medicare Services. These services we provide are free to the public. They offer neutral, objective information to clients and the public. There are 128,000 Medicare beneficiaries in Vermont, and in 2021, the AAAs themselves assisted 7,254 Vermonters and adults with disabilities with Medicare and health insurance issued, delivered 52 workshops on Medicare, what we call Medicare boot camp, but beginning for people coming on to Medicare. During the 2021 open enrollment, we assisted close to 3,000 people to change their Medicare coverage, join, switch, or drop a Medicare drug plan, also known as Part D. Also, we assist people with education around Medicare supplement insurance, which is also called Medigap insurance, and the Medicare Advantage plans, which are also known as Medicare Part C. Medigap, as Ruby related, fills the gap in the original Medicare coverage and is sold by private companies. Original Medicare pays for much, but not all of the costs covered by health insurance, and a supplement plan can help pay the remaining healthcare costs, such as co-payments, co-insurance, or deductibles. The rates for these plans are not put forth for the new year. In many cases, it comes well after the new year. This sometimes leaves a person attempting to explore options without full knowledge of an informed decision. Medicare Advantage plans are an alternative way to access Medicare. They are sold by private insurance companies who administer Medicare for the federal government under rules set by Medicare. The number of Vermont insurers for the Advantage market has increased from 3 plans with 11 options 3 years ago to 5 plans with 22 options today. Advantage plans are heavily marketed through celebrities on national television, social media, print ads, and Google ads, along with stacks of mail that people come into us with, which is quite amazing. Additionally, many receive calls from their current supplemental plan offering a better benefit, only to understand that they were switched into a Medicare Advantage plan without realizing it. In 2021, the AAAs received 3,009 requests for assistance with Medicare Advantage plans compared to 2,467 the year before. Those new to Medicare and those who are already Medicare beneficiaries are inundated with ads which make assurances about the plans which don't always bear out. Some facilities and primary care doctors may be outside of Advantage plan networks and unbeknownst to the beneficiary. For example, some enroll in a plan, then need rehabilitation, and services during a nursing home stay may be denied, and they don't accept the Medicare Advantage plan at the nursing home. So we have people who have literally been stuck in hospitals because there's no alternative option for a rehab stay based on the Advantage plans. As people begin to explore these bonus entitlements, you see them all on the ads for vision and dental in particular, they often face a limited provider option. So a dentist in Burlington may be the only option for somebody living in the Northeast Kingdom. Many Vermonters are confused about Medicare Advantage options and are reaching out to area agencies on aging for neutral advice and counseling. It can be difficult to disenroll a Vermonter from an Advantage plan and then to re-enroll into a prior benefit within the first year, which is allowed under Medicare. If too much time has elapsed, meaning it's more than a year, then these requests are typically denied. The AAA network supports Section 1. We support the provision of amending SVSA 480 to allow Medicare supplement plans after the 6-month period following a beneficiary's 65th birthday without the current status, which allows the insurance company to decide whether to enroll a person or not. Beneficiaries may need more than 6 months to determine their healthcare needs and their healthcare costs that they're not aware of. In general, what we see is people assume Medicare is going to give them full coverage, and that's really not the case. Establishing an annual enrollment period for enrolling in or changing a Medicare supplement is also something we support. We propose that requiring rate increases to be approved prior to open enrollment period. And I can just say that I went to the DFR site yesterday and pulled up, and there are still plans that have not shown their increase for 2022 yet. It's not recorded there. We also support convening a stakeholder group to study options for Medicare supplement plans and Advantage plans. But more needs to be done to explore these problems and the confusion due to the Advantage plans. The stakeholder group should explore funding to increase staffing. There are currently 5 area agencies on aging, and there's 5 SHIP counselors for the state. Clearly, the increased aging population in Vermont requires more to meet the need. Prevention of misleading or incomplete information in Advantage ads in Vermont is another key focus that needs to be taken up by the stakeholder group. And public education about Advantage plans to improve understanding of coverage, cost comparisons, and provider networks. As leaders in the state, we work to educate and support elders, and the AAAs would like to have adequate representation in the stakeholder group. Thank you for the opportunity to address this important subject before the Senate Health and Welfare Committee.
Meg, thank you very much. I didn't see your testimony on the web page, and perhaps you've already sent it in.
I
Can
did
you-
not, but I will send it in. Sorry.
Yeah, just send it to Aaron. That would be
Mhm.
terrific, because there's a
Okay.
lot there. This is all helpful. Senator Hardy has a question.
Yeah, I have a question of clarification. I may have misheard you compared to what Ruby just said, but are these plans, are people able to get out of these plans? It sounds like Ruby said they couldn't once they're in them, but you said that
They
they
can in the first year.
in the
they-
first year only. Okay.
Yeah. And the challenge at that point is they can go back to their supplemental plan. However, they have to know to do that, and they have to know to advocate for themselves. And that's where it gets a little tricky. And the second thing is that the supplemental plans, at times, different plans phase out. Those are pre-prescribed by Medicare. So I call it the alphabet soup, A to N. But over the years, we see, for instance, we had someone call last week, and he has a J plan that's no longer available in the state of Vermont, but he's grandfathered in. He got switched to an Advantage plan that he didn't realize. And we ended up having to advocate to get him put back on his J plan, because he knew for him that was very valuable. He has cardiac issues and is often requiring medical intervention.
Okay. But if they miss the window in the first year to switch out, then they're permanently in and they can't get out without.
Well, they can end it, and then it's up to the insurance company to decide if they want to underwrite them for a supplemental plan.
I see.
So they go through an interview process to see if they're eligible for that.
Okay.
And I'll give you an example. We had a woman this past open enrollment period who was attempting to do that, applied to one of the companies that provide supplemental plans. It was a half-hour interview on the telephone with her paper application. And in the end, even though she was taking no medications, she had not been in the hospital, was getting regular routine medical care. She was denied because she was 20% overweight in the end. And that was like question 39. It was the very
Right.
last thing. So it really puts people in a very awkward position to get into an Advantage plan or switch.
Wow. Okay.
Thank you, Senator Hardy. I was thinking that.
Okay. Thank
You're
you for
welcome.
your testimony.
Any other questions for Meg? Okay, this is helpful. And when you get to be the age to sign on to Medicare, you don't have all the questions in hand, and some folks are pretty healthy at that point, so you don't think ahead, right?
Correct.
Yeah.
And I
okay.
think people also have the false sense that Medicare is going to cover everything. And then it's a very rude awakening when they start to explore what it actually covers and what it doesn't.
Okay. Michael Fisher is here. And Michael, do we have your testimony on?
You do, Senator. I'm
Good.
thinking on my feet here, literally, that I provided
Oh, good.
a PowerPoint presentation, but I think I won't put it up.
Oh, darn. I was hoping you would. It looks good.
Well, I'd be happy to if you want. I was thinking that
It's up to you. It's your testimony.
I'm going to speak generally from it.
Okay, good.
And,
Okay.
and people can follow along if they'd like. But I think that the previous testimonies covered a number of points that we made in this presentation. And so.
I will say that redundancy is not a bad thing.
Okay.
But please introduce yourself, and we look forward to your testimony.
Thank you, Senator, and thank you, committee. I am Mike Fisher. I am the Chief Healthcare Advocate at Vermont Legal Aid, and we have been working on this policy area and promoting a change in this policy area for a number of years. Just a brief legislative history: we promoted a bill introduction last biennium that was introduced by Representatives Lamfer and Iacovone. And that bill did receive some attention in House Healthcare and a discussion of the need to create a work group to really sort out what the right thing to do was on this policy area. And then COVID hit, and we didn't do it, and for obvious reasons. And so this biennium, we came back and said, let's make another push at it, and had a House version of this bill and a Senate version of this bill introduced. So I'm very appreciative to be back here having this conversation. I have to couch everything I say in the real words of Vermonters who reach out to us and who have talked to us. And so I want to just read a few quotes that have come to us from people who tell us that they're from Vermont and that they're on Medicare. I put off going to the doctor with increasing frequency now that I'm retired and on Medicare. This was not a problem when I had good medical insurance. I constantly put off care. I have insurance, but never know what my obligation will be. Once you enter the medical system, it's a black hole of expense. Constant worrying and stress. I paid for my medical debt with my pension and savings. Medical debt makes life scarier. These are the voices, these are the motivations for us to promote changes. So again, just very basic, traditional Medicare pays 80% generally, leaving Vermonters, US citizens with a significant expenses, and a potential for 20% exposure. And then the main point that we want to emphasize here, or a main point we want to emphasize here, is too many Medicaid enrolled Vermonters have no secondary coverage. We think this is a substantial problem in our marketplace, and it plays out in a tremendous amount of bad debt and generally uncompensated care in the provider system, and I'm sure denied care. So as has been recognized, Vermonters have currently a 6-month open enrollment period that begins the month that they turn 65 and enroll in a Part B plan. During the 6-month open enrollment period, Vermonters can buy any Medigap policy, even if they have significant healthcare problems. Vermonters who fail to purchase during this window lose the guaranteed issue protections. And so that, I think, the exchange that just happened between Meg and Senator Hardy about what happens to people when they attempt to buy a Medigap policy after, I want to confirm that I'm saying the same thing that Meg was saying. It is the loss of the guaranteed issue protections that we're talking about here. So an annual Medigap open enrollment period with the protections we're talking about will help Vermonters secure coverage. And I also just, we need to recognize Medicare is changing. Medigap plans have been around since, I think we see 1992. But in the meaning of the age 65 and the meaning and sort of the landscape of Medicare has changed a lot and is changing a lot. Part C or Advantage plans are a significant factor today. And so the whole dynamic that's been described by the previous witnesses is a major motivator for us here. Similar to what other people said, people call our helpline when they discover that their Advantage plan doesn't work for them. And that happens when they need care. It doesn't happen on a scheduled, first year of their enrollment. It happens when they need care. And so they discover that a retired football star didn't tell them exactly what they needed to know, and that the plan that they're on doesn't meet their needs, and the flexibility that this bill would provide would go a long ways in helping Vermonters get to the kind of care that they need. This isn't a radical idea. I think Ruby said it really well. Every other state regulated health insurance product has an annual open enrollment period. And so, you know, we address concerns about people waiting to buy coverage until they get sick with the concept of an annual open enrollment period. There are a number of states around us who have a continuous open enrollment. New York, for example, we didn't suggest that here. We suggested an annual open enrollment period because we didn't want to deal with the adverse selection like arguments. The people are going to wait until they get sick before they come get care. And then I also want to recognize, well, I have, of course, looked at the testimony from others and want to recognize that folks from the insurance industry will express concerns about the cost to consumers related to this proposal. And I have a few things to say. One of them is, of course, you can reduce rates if you keep sicker people out of your pool. It's the oldest insurance game in the world. And so, you know, that's number one. It's not a good way, because when you keep people out or you give them a increased cost or penalty if they join at a different time, then they still get sick and they still need care, and it just shows up more in uncompensated care for our providers. And then lastly, a point that I think is important, that any organization, company that is selling a Part C plan has an interest in maintaining the status quo. The flexibility that this bill provides for, and again, I think, you know, the previous testimony said it really well, provides for real competition, provides for people to have the choice to be able to get to the plan that they want instead of being stuck. And it's, I fully understand why a company that is selling a Part C plan here in Vermont wouldn't like that. Lastly, just a reminder, it's been said before, but 4 of our neighbors have this. Connecticut, Maine, Massachusetts, and New York have either an annual or a continuous open enrollment period. So we would be joining our neighbors. Finally, we support the work group. We think the problems, as I said earlier, about the number of Vermonters who are on Medicare with no secondary coverage is a bigger problem than this bill, than Section 1 addresses, and something that really needs some thought about what to do about it. Senator, I have one technical and one more substantial suggestion in changes to the bill that I'd be happy to mention here, but also go over with Ledge Council if you think that's appropriate.
Well, sure. Why don't you share what you have with us, and if you don't mind sending in an email, sending it in, and then the committee will look at what you have, and then we can decide how to proceed. Jen certainly would be the one to put it in appropriate language.
So the technical one is in Section 1D1.
Was that C1 or B1?
D. It says upon attaining 65 years of age, and we wonder whether it should say upon attaining 65 years of age and are enrolled in Part B. That's technical. It's a question for Jen Carby as to whether that's needed in order to be accurate.
Yeah.
And the second one is that the bill calls for an annual open enrollment period to be consistent with Part D open enrollment period. And we believe that it makes more sense, and this is our bad because we're the ones who suggested that originally. But upon
Uh-oh.
reflection, we think it makes more sense for the annual open enrollment period to be consistent with the federal annual Medicare Advantage open enrollment period, so that during that time period when people are getting advertised about Advantage plans, they also have the the annual open enrollment period for.
What page is that? Do you have the page number? Okay,
I
that's,
don't have-
go ahead.
it's right in that first section as well.
Yeah, I see it. Yeah, okay. All right.
So those are the two suggestions, and I didn't write them down on the presentation I gave you, but I'm happy to write it down and send to you.
That would be great. And just make sure you copy Aaron on these suggestions. Okay, good. All right. Meg, did you want to add to your testimony briefly? Go ahead.
I just wanted to make a comment that people who are under the age of 65 also have access to Medicare if they're disabled for 2 years. So this is not a discussion that is only for people over 65.
Okay, that's important. That's an important distinction. Thank you. Okay, Senator Hardy.
Thank you, Madam Chair. Well, in that case, do we need to change some of the language? Because so much of it is about being age 65.
Well, so what we'll do is, this is a very good question and a comment that Meg has made. So as we go through the bill with Jen again and look at possible markup, please remember to bring this up.
Yep.
Yeah.
And Meg, if you can look and see if there are places in the bill or Mike that we should change because of that, that's a really good point.
Yeah, good. And
I think-
yeah, just send it in. Make sure you send it in to Aaron. We'll get it, and then we'll be able to share it as we go through the bill. And Jen Carby will be able to see it. Okay. All right. Thank you. Any other questions, committee, for Mike Fisher on this? Please stay around, because it looks like we're going to have a little bit of time for discussion, and this is a good thing. So Emily Brown is here. Thank you for being here and welcome.
Yeah, thank you. My name is Emily Brown. I'm the Director of Insurance Regulation at the Department of Financial Regulation. And so I didn't submit any written testimony today, but I thought I'd just talk about DFR's role and then, our take on the bill. And I would be, happy to provide written comment after if needed. So currently, the Department of Financial Regulation is charged with regulating Medicare supplement plans. So that means that we approve any rates that are filed or are requested in the state. We also review the forms to make sure they're compliant with our regulation as well as federal law. And then we are also charged with reviewing any advertising. So any advertising that happens in Vermont for Medicare supplement plans, the department, using its regulation as well as our state law, review those advertisements to make sure that they are not misleading to consumers in the state. The state of Vermont and DFR does not have the ability to regulate Medicare Advantage plans or the advertising that they use. I actually checked in with our Consumer Services Division, who takes a lot of the calls around consumer complaints. And the main complaint they hear is about Medicare Advantage plans, the exact concerns that were raised by other witnesses, people not understanding the benefits, not understanding that when they are switching plans, that they are not entitled to the same benefits and that their networks may change. So all of the concerns that were raised earlier are real. What I would say is, and just to put a finer point on some of the comments that were made earlier, is that Medicare supplement, like major medical, is community rated, meaning that if you buy a policy in Vermont, you will pay the same rate whether you're 70 or 80 or 90. The purpose of the open enrollment period as it currently exists, where it being the 6 months when you turn 65 and are also enrolled in Medicare Part B, is to make sure that if you want to enroll in a Medicare supplement plan, you do so during that period. And what that does is keep costs down so that you don't have, as Mike said, adverse selection, people enrolling when a health issue arises in the future. And that provision, why many states have that provision, is again to keep rates lower to avoid adverse selection. One comparison was drawn to other health insurance that's available in the state. Major medical specifically has an annual open enrollment, but what major medical also has is a requirement to purchase. As some of you might remember, there was a lot of discussion around this a few years ago when the tax portion of the individual mandate was repealed. So while the tax portion was repealed, there still is a federal requirement to purchase major medical insurance. Granted, not everyone does that because now there's not the tax implication. But I just wanted to point out that difference in that there is no requirement to purchase Medicare supplement. And it's that initial open enrollment period, which is acting kind of analogous to the requirement to purchase that you see in the major medical market. So again, just the open enrollment period is meant to prevent adverse selection and keep rates lower for everyone. And why that's important, especially with Medicare supplement plans, is because you're dealing with a population that's on a fixed income. So if you open the enrollment period to be more often and potentially push up rates, you're going to not only push up rates for those individuals, you're going to raise the rates for everyone possibly. So it's just something that I wanted to point out as a consideration if an annual open enrollment was allowed. I agree with all the other pieces that were said about education. I think there's a lot of, again, misleading advertisement that's happening with Medicare Advantage. I think people not only don't know the differences about Medicare Advantage, but they don't understand maybe when they need to enroll in a Medicare supplement plan and then may potentially miss that initial open enrollment period. So more work, I think, does need to be done around education, making sure consumers understand their rights with these plans. So, the department does support doing a study and looking at this market, but I think we just would be a little more reticent about supporting Section 1 due to the fact that if this change was made without knowing what the causes or the issues in the market are currently, it could disrupt the current market rates and then lead to higher rates without maybe taking other proactive measures before that point, which could, again, work to educate people, get people into these plans during the open enrollment period. So I just wanted to bring those points to the attention of the committee and suggest that we do a study of this market before making any changes to any open enrollment period.
Emily, thank you. And it would be extremely helpful to have your testimony in writing.
Sure.
So you can send that into Aaron and we'll get it.
Great. Okay.
So, and before we go to Senator Hardy, I do have a couple of questions. The first one of which is, has DFR considered providing educational information to the public?
Yes. So I believe currently our Consumer Services Division works with Cove and SHIP on providing information to consumers. I can't speak directly to any kind of outreach or education, but I do know that whenever we receive a call or consumer complaint, our consumer services staff are always, providing information to consumers around options for Vermonters, especially around Medicare Advantage plans and the Medicare supplement plans.
So it's more of a complaint-driven process rather than proactively, getting information out there that might counteract some of the information that we can't control.
Yeah, I would like to maybe get back to you on that. I know that
Okay.
I know that they do a lot of work. I'm just not sure if they've done specific, sometimes they'll do seminars on certain issues, and I'm just not sure if they've done any of those in the past few years. So I'd like to just check in with our team at DFR and see what they have done for consumer outreach.
Yeah, I mean, it's very difficult to think about how do you reach people who are in the middle of some of these decisions and are clueless about what it
Right.
means. Yeah. Okay. So thank you for that. And then another quick question. As our healthcare advocate, Mike Fisher, has said, some of our neighbors like Maine and Massachusetts, Connecticut, New York have provided for the open enrollment process. And what are we learning? Have you been in touch and learned something from them?
Yeah, so I actually have not been in touch. I did read Blue Cross's written testimony that kind of had a comparison of rates among the states who offered the annual open enrollment versus those who didn't. And it seems like that, according to their testimony, that the rates in states that allow an annual open enrollment seem to be higher. I can point to something that's more directly related to Vermont, in that Blue Cross Blue Shield Vermont currently has a plan that has a continuous enrollment. So meaning that if you are on a Medicare Advantage plan and you want to switch back to a Medicare supplement plan, there is currently one plan available in Vermont that allows that, and it's offered by Blue Cross. And so if you look at the Blue Cross rates for that plan versus the plan that does not have an open enrollment or an annual open enrollment period, which is the TVHP plan, you can see directly there that the cost of the TVHP plan is significantly lower, because that plan is only available during the 65 age 65 open enrollment period, and not open as the other Blue Cross plan is. So right there, you can see the impact of allowing a continuous open enrollment period does have a higher upward pressure on premium for that plan. So I imagine if all plans were allowed to have an open enrollment or required to have an open enrollment period, it would push up premium in the same way that it's done for the Blue Cross plan.
So, and then on the other side of that, we've also heard that the costs for the patient
Yes.
are exacerbated when they
Yes.
are, yeah.
And it's a balance.
Yeah.
I agree.
Okay, so yeah, so thank you for bringing us another conundrum. So very helpful, everyone. Senator Hardy.
Thank you. Thanks, Emily, for your testimony. I'm confused, so I'm gonna ask you to help me understand.
Sure.
The Medicare supplement, I'm looking at the bill, versus Medicare Advantage.
Yeah.
They're two different things. And
Two
I know
different
we've
things.
just been explained this, and this is just showing how complicated this is, because I'm on this committee and I'm still confused. So could you explain the difference between those just really briefly? And then I have other questions once I understand that.
Sure. So Medicare supplement plans are regulated by the state of Vermont. All the benefits, all the plan designs, I should say, for Medicare supplement, you heard Meg earlier talking about the alphabet soup, so A through N. All of those benefit designs are universal. So there's no, an insurer offering a Medicare supplement plan can't, for instance, add benefits to make their plan more attractive. They have to offer the standardized benefit design that's dictated by DFR regulation 0904. The difference in the Medicare Advantage plans is that there's a lot more flexibility around the benefit design. So as mentioned before, those insurers can add, for instance, a dental plan or a vision plan or a gym plan, but they can also use more restrictive networks, which I think, I know the department has heard about and that we've heard about generally. So if you go and buy a Medicare Advantage plan because you're attracted to this dental or vision plan, like was mentioned earlier, yes, you might have dental, but the network for the dental service might be really small. So you actually don't have access to that benefit. So I think there's a real transparency issue happening in the Medicare Advantage plan, because they're not standardized, many people don't understand that when you buy those, you're not getting the same access to care that you would with a Medicare supplement plan necessarily. I'm not saying that's across the board and the same for all Medicare Advantage plans, but what I'm saying is that there's not the uniformity that you have with a Medicare supplement plan. So any Medicare supplement plan you buy, you'll know ahead of time what the plan design is. It's very transparent, all of the plans. So if you buy a plan F from Aetna, you're going to have, and you are looking at a plan F from Blue Cross, they're going to have the same exact benefit design. There is no variation, which makes it a lot easier to price shop when you're in that initial open enrollment period. So you can say, okay, Aetna's, this price, Blue Cross is this price, and make your decision. You don't have to kind of dig into the details to say, okay, what's better in this plan or that plan. It is not that way for Medicare Advantage. There can be several differences among the plans. And then I think the most important thing, and what has frustrated the department, is that we do not regulate Medicare Advantage plans. So when we get a Medicare Advantage complaint, we have very little ability, aside from maybe actions of the producer selling the plan, or other things that might fall into our Unfair Trade Practices Act, which kind of regulates the conduct of insurance, or the business of insurance in the state. We don't really have the ability to enforce anything on the Medicare Advantage side. That all falls to the federal government. So that's, I think, also, an issue, is that once people get into those plans, it takes away the ability of our division to really help people when they run into issues. Also, another thing I was thinking about listening to the other testimony was that if the result of creating an annual open enrollment did push up premiums for the Medicare supplement market, that could potentially make those plans less attractive to people, and could push people into the Med Advantage plans, creating more of a problem. So again, I'm not saying that would happen. I think there's a lot of issues and a lot of change, as Mike said, happening right now. And I feel like we need to understand as a state all of those changes that are happening and all of the issues before we are then making a policy decision. Because what I'm hearing from the testimony is that it is Medicare Advantage is the main concern. So making a change to the Med Sup market, while it might allow those who have issues in Medicare Advantage to come over, it might not solve the underlying problem of what's happening right now, and consumer confusion, and lack of access to benefit and care. So,
okay, can I just continue to get a
sure, sorry.
No, you're passionate about it, and that's awesome. So that's helpful. So the supplements truly are supplemental to a regular Medicare.
Exactly.
The Medicare Advantage, basically, that's the one that replaces a Medicare, regular Medicare plan.
Yes, thank you for pointing that out.
I finally got that.
Yes.
And why? So I wrote down that you can't regulate Medicare Advantage plans or their advertising.
Right.
Is that because they're under the same kind of umbrella as the self-insurance, the sort of ERISA plans, or why can't you regulate them?
It's a different, it's not, Medicare Advantage does not fall under ERISA, but it's completely Medicare Advantage. And I'm sorry, I don't know the actual citation to federal law, or what law it falls under, but because the Medicare Advantage, like you said, is replacing Medicare, original Medicare, and the supplemental piece, it's all regulated at the federal level. And states do not have the ability to require Medicare Advantage to file like Medicare supplement does their advertising or any of those materials that they use. And I am not sure if Medicare Advantage plans are required to file their advertising with the federal government, or if there's, some standards out there, but the state of Vermont do not have the ability to pre-approve any advertising that happens on Medicare Advantage. And I can look into that for you and see if there are any federal standards around advertising. I'm just not sure.
Yeah, that would be helpful to know what we're able
Okay.
to do. And if we can even say, the state of Vermont cannot regulate these on everything, saying, so people know that the state of Vermont
Right.
can't do it. I don't know. Just, I have been getting my mother's mail since she passed away. And so I've like stacks and stacks of advertising about these, and it's super confusing. But, okay, I had another question, but I can't remember. So, but thank you. That's helpful.
We can come back to it, Senator. I think, yeah, this is good. I was just thinking that there is now one advantage to being a little bit older, and that is having some experience with this whole area. That maybe that's it. Mike, go ahead. Why don't you add in? And then
Right.
we do have one more witness we want to hear from, and then we'll get into more discussion.
I guess I just want to say again, I am certainly very concerned about Vermonters who have Advantage plans or Part C plans who that don't meet their healthcare needs, but I'm equally and maybe more, I'm equally motivated here by the numbers of Vermonters who have no secondary coverage. Those Vermonters are very highly exposed and represent a tremendous hole in healthcare coverage in Vermont.
Okay. Senator Hooker.
Thank you. I just want to go back to the rate settings or who determines when those rates have to be published? I mean, Meg said that here it is after, how many weeks after the enrollment period and the rates are still not published. Who determines when
Yeah.
those have to be published?
So the way the system currently works is there is no filing deadline, for instance, for companies to file their Medicare supplement rates with the state. So sometimes we have companies that will file in August because they know that people will be shopping through the October, December open enrollment period and looking for new rates, especially if they're looking to switch plans. But as I said, what we currently don't have is a filing deadline. So sometimes what will happen is insurer will file maybe in September, October. And those rates obviously have to be reviewed by our actuaries or actuarial consultants at the department. So what ends up happening is sometimes that delays the timeline and ends up delaying the publishing of rates. What we have talked about is maybe adjusting our regulation to require insurers to file by August or a set deadline to then ensure that rates would be available to consumers by the open enrollment period, so consumers can make an educated decision about their rates. I think that's something that we've heard concerns about and needs to be addressed. I'll also just circle back to, I know there was a comment about the rates on the DFR webpage. We have in the past published Medicare supplement rates for companies that allow us to publish their rates. So what we try to do after the rate is approved is we'll reach out to the company and ask them to send us their published rate for their plans, A through N, and then they'll send us those. Sometimes companies actually refuse to send us those rates. They're not required to, for instance, allow the department to publish the rates on our website. So I think what happens is, unfortunately, sometimes there is some consumer confusion when they visit the DFR page. What we always try to suggest is that if you want to have a quote from an insurance company on your Medicare supplement, that you reach out to the company directly. But we have tried to provide some information for consumers on the DFR webpage. It's just hard with our existing resources to keep that up to date sometimes, especially with the rates not being all approved at the same time. So I think it's something we recognize we need to work on. Yeah, there's work to be done there.
Okay, thank you. And if I may, and I don't know, this may be a longer discussion, but can somebody tell me what this is doing to Medicare, original Medicare, the whole
So
market, Advantage market?
yeah, so the bill the bill itself wouldn't have an impact on Medicare. It would just change the current practice for the enrollment in the Medicare supplement plans. But what the Medicare Advantage plans do, as Senator Hardy said, is that they replace original Medicare. So someone might be enrolled on Part A and Part B and have a Medicare supplement plan. And if you join a Medicare Advantage plan, you're giving up your Part A and Part B and switching to a completely privatized or commercial Medicare plan, including the Part A, Part B, and the supplemental coverage. So it's a complete replacement for Medicare and Medicare supplement.
So it's taking people out of Medicare and
Correct.
putting them into private insurance.
Exactly.
Probably healthier ones.
That's been a big concern for a number of people. And I think maybe one of the motivating factors for looking at all of this, but among others. Any other questions of clarification? So, and then, good. Okay, Senator Hardy.
Thank you, Madam Chair. And I know we have one more witness. I don't want to take his time.
That's okay.
I've remembered my other question for Ms. Brown, which you said something about you were comparing the Medicare supplement plans to major medical and how major medical has an open enrollment period, annual open enrollment period, but they're required purchase plans.
Exactly.
But those plans, still people can have choice throughout their coverage. So they can, during an open enrollment period, they can switch to another plan that gives them better coverage or cheaper coverage.
Correct.
And so my understanding of what the bill does and what the previous witnesses are asking for is that this would actually be more comparable to major medical, is that it would give patients or people the ability to switch to a plan along the alphabet soup that might provide them better coverage, just like with major medical.
Yeah, and I'd say you're exactly right, aside from the requirement to purchase. So the idea is that currently, no matter your health status, you're supposed to be purchasing major medical insurance. And you're exactly right. You can switch plans. You can, go from, a silver to a bronze, whatever you want to do. But every year you should be purchasing major medical insurance. And what this does is keeps the pool large, which is when community rating works at its best and keeps rates lower for everyone. Everyone is in. What this bill would do is, because essentially what the current Medicare supplement open enrollment period does is it incentivizes people to purchase the policies when they're eligible to during that initial open enrollment. So because they know if they don't purchase it, then they will be subject to potential underwriting and penalties. So what that mechanism is meant to do is have everyone in the pool who wants to be in. So you're keeping that pool stable for everyone who's in the pool and keeping rates stable as time goes on and you're into your later years. What the bill would do is and again, I'm not saying it will, but I think we really need to understand what it would do. But a potential issue is that if you decide not to purchase your Medicare supplement policy, you wait, you end up having a severe health issue. And at that point, you decide to purchase your Medicare supplement plan. If everyone is allowed to do that and just wait till they have an illness to purchase the plan, what could potentially happen is that you then have a pool of people, because there's no incentive to purchase it during the open enrollment period. You have a pool of people who have higher claims experience, or less healthy, or have higher medical needs. And what that will do is drive up claim experience, because there's no incentive to pay a monthly premium throughout all of your plus 65 years, because you know that you can just purchase it whenever you need it. So I think there is a comparison there with major medical. I just think it's about the kind of the carrot that you're giving people to purchase a policy. And if you take that away, you're then just having the policies and allowing people to join and leave whenever they want, which could then drive up costs because the pool of people who are purchasing are really only those who need it. And I think there are examples from other states. We can look to that, but I really think we need to understand what's happening in Vermont and what we can do and what makes sense here, because we are a small state too, remember. And with a smaller pool could come more variation in premium. So I just think we need to be careful and measured in any decision we make, and understand what potential impact it could have on Vermonters, especially, as I mentioned, those who have limited incomes and aren't able to afford any variation in premium over the years that could potentially arise.
Okay, I'm going to suggest this is a great conversation, and I think we probably are going to have to continue it with DFR in the room. But I'd like to hear first from our last witness, Senator Cummings. I see you
Yes.
now.
Hi, Emily. I usually see Emily in
Hi.
the afternoon. And this really is getting into insurance rates and insurance pools, which really steps over
Into finance.
into finance. I'm assuming this is going to go to finance. I think I'll request that it does, but it might help us if we talked about what happens to people's health, and then let us worry about what happens to the insurance pools or prices.
Right.
That was my
really is
question
where we
earlier. What
stand
happens to the individual?
time.
Yeah.
Yeah.
So I was thinking the same thing as Emily was talking, that this does step into finance. So we'll have to consider where we are with a bill, and then go from there.
I'm just
All
getting
right.
worried about time.
Yeah. So right now I'm thinking about our next witness who is here with us, and I'm going to try. So it is Rant Jamgoshian.
That's good. Haran Shamgoshan. You got it. Thank you.
Wow.
You sound
Rant. Okay. I just did okay. But thank you for being here. And we look forward to your testimony. And as you've heard, it's helpful to have your testimony sent in writing. So if you can do that, that'd be great.
Sure. I believe it was sent in on Tuesday to Aaron. I'm not sure if it's been circulated.
Well, let's see.
But I'm not going to get too much into the testimony. I just want to highlight a few points. So I serve as the CEO for Dialysis Patient Citizens. And so we represent about 815 Vermonters who have kidney disease or kidney failure and rely on dialysis to stay alive. About half of those, about 425, are under the age of 65. And I think it's really important to remember how vulnerable this group is. So 1 in 3 of our members are actually food insecure. So they go to bed at night, not knowing where their next meal is going to come from. And I think, the point was made about the fact that, there is the ability for Vermonters under 65 to purchase Medicare supplemental or Medigap plans. Unfortunately, when that provision was enacted, insurance companies, I think rang the alarm bells about skyrocketing premiums, and ESRD patients were excluded. And so that's the reason why, I wanted to testify not only in support of this bill, but that the work group look at access for these patients, ESRD patients, kidney failure patients, under the age of 65. If you take out the dual eligibles, it's just a couple hundred patients. But I think, what people really overlook is the impact, on patients. I mean, this first and foremost, it's not just about providing financial stability. Medicare, I think people forget there's no out-of-pocket maximum. I think that's why a lot of people are swayed to go into Medicare Advantage, because especially if you're a dialysis patient, and now if you're under 65 and you may want to roll in Medicare Advantage because you've got a limit, whereas the average dialysis patient, the coinsurance costs of 20%, it can run $20,000 a year or more. So having the committee also look at access for Medigap patients, for ESRD patients and Medigap, be very much appreciated. I do want to highlight a couple other points. I mean, I think, one of the things that's overlooked is that while everyone's focusing on Medicare Advantage and misinformation, patients may actually make an informed decision. They may enroll in, at the time, what may be compelling. So I think of dialysis patients who are told you can't get a transplant because you've got multiple teeth that need, dental work. And so they might enroll in Medicare Advantage because of that dental benefit. But it might take 4 or 5 years before a transplant organ becomes available. And by that point, the Medicare Advantage plan may have eliminated that dental benefit. So these benefits also, the Medicare Advantage benefits also change, from year to year. And that's, I think, the second point on why it's so important for dialysis patients to have that access to supplemental, because a lot of transplant centers won't even consider patients for a transplant if they know that the patient can't afford, to pay that, additional 20%. And so that's one of the reasons why it's so critical. If you want Vermonters to have access to transplant, especially if you think of the under 65, that's the age where patients are most likely to have successful transplants and live longer, healthier lives on a transplant. And so that's, one of the reasons why we'd like to study access for dialysis patients under 65. I think another point I wanted to.
Oh, you're going out, Harat.
Am I going out? Can you guys hear me?
Yeah, you're okay.
Sorry about that. I'm sure I have a microphone. The other thing I want to kind of bring up is that it's not just shifting from Medicare Advantage to Medigap. Patients may enroll in a Medigap plan that is the most competitive at the time that they enroll. But when I was testifying in Maryland last year on this same exact issue, there were other patient advocates who talked about how their premiums went up significantly. And they just wanted to have the opportunity to go ahead and consider another Medigap plan of equal or lesser value of coverage. And unfortunately, it's the whole Medicare, it's the whole medical underwriting issue. So, a lot of us take for granted that there's a whole ban on pre-existing conditions, but in supplemental insurance, if you decide you want to go, from Blue Cross to Aetna or a different plan, well, they can go and look at your health status. And those patients who did try to change plans testified about the fact that, their premiums were doubled or tripled because of their health underwriting status. And therefore, it just wasn't a viable option, for those individuals. And so I think at the same time, you kind of heard the impact that, by having all these patients go to Blue Cross, because that's the one option available in your state that increased their premiums. I think that almost is a call to action for the committee to do something, because they're trying to do their best. They want to help Vermonters. And so their rates are going up. And if there's the requirement that there's an open annual enrollment, then you're spreading the risk among all the various insurers that are offering those options available. And so I think, on the one hand, while, the alarm bells are going off about potential rate increases, I think, you need to kind of look at, as long as there are those who are trying to do us right, they're being penalized for trying to help out your citizens. And if you create a level playing field, if you create open enrollment for everyone, then that just drives down the potential increases, drives down the costs for everyone. And so that's the flip side of the argument about, skyrocketing rates, skyrocketing increases. And, I want to thank the committee for looking into this issue. It obviously has a significant impact on those individuals who are trying to figure out, do they pay for their medications or do they pay for their rent? How do they cover the day-to-day cost of living? And, on the one hand, I understand the desire not to want to see premiums increase, but generally, even when, the 30 plus states that have covered dialysis patients, they've seen minimal to almost no increases. And even those that have looked at providing access to disability, which covers so many more patients, have also seen minimal increases. And so, when you think of the natural progression, providing patients with the choice, the opportunity to look at if things change in their Medicare Advantage plan, if things change in their Medigap plan, they did the best that they could at the time. And, why do we let, young, healthy people change plans year to year, but don't provide that same access for everyone else? And thank you again, for your time. Happy to answer any questions the committee may have.
Thank you very much. Thanks for your patience too. And we do have your testimony. I think folks may have to refresh your page and you'll see that you have two documents from Harant. Thank you. Are there any questions of clarification? Simply because I'd like to give the committee a break before we move on to our next bill. So go ahead, Senator Hardy.
It's just really small. Thank you, Mr. Jamgoshian, for being here. Are you a Vermont organization or a national organization?
So we're a national organization with members, in Vermont. And after spending my, Christmas at Okemo, holidays with my son, I, was asked and welcomed the opportunity to testify on this issue because, we do have several members in the state who'd be directly impacted by this issue too.
That makes sense. So you've testified on this issue in other states that are making this switch or thinking about this switch.
Exactly.
Got it. Great. Thank you.
And that's why I refer to Maryland. So my apologies. I should have, clarified that.
No, that's okay. I was just curious. Thank you.
Senator Terenzini.
Thank you, Senator Lyons. I'd just like to thank the witness for coming and talking so eloquently about dialysis and what the patients go through. It's near and dear to
We're losing you, Senator.
You're in and out, Senator. Senator
I'm sorry, can you hear me
Terenzini is
now?
locked. Now I can hear you. Go ahead. You're locked. Senator, unfortunately, you're locked. So we'll get your comments as we go through the bill. And I think we heard that you were appreciative of what the previous witness had said. I can't say any more than that because that's what I heard. Okay. Folks, I think, unless there's another question of clarification, what we're hearing is that this is an important issue for many people, that it may raise costs for individuals who then can't afford their health care, that people are seeking open enrollments, that there are some folks who have been left out, and that the bill should probably pass over to finance at some point. So we'll try to put this on our agenda fairly early when we get back from town meeting or before that, so we can have a broader discussion about how to improve it. I already have my own ideas and we'll just talk together as a committee. But I want to give us all a break because we've got a long list of witnesses coming up. How does that fit? Good. We're doing it. All right, good. I do think we want to move forward on this bill one way or another. It seems like it's a very urgent issue for a lot of people. And we've heard from DFR, their concerns about the information people are receiving and how to sort out the whole rate issue and the cost issue. I think welcome to the world of finance. And Senator Cummings, you're right. You may see this bill.
Seems like, Madam Chair, we might need another letter to our congressional delegation too about
listen, Senator, I drafted a letter. I don't know, it was last year or the year before, and I asked to have it put together, and it's a list a mile long, including this one. But so we'll work on.
Well, we wrote to them about diapers, so we can.
Well,
write to them about,
I've got a list. It includes ERISA and it includes Medicare. So we need to. We'll work on that.
Cradle to old age.
Exactly.
Cradle to old age. All right, let's take a break. We will be back at 10 o'clock to talk about birth centers. And thank you very much for your testimony. We greatly appreciate it.